Professional satisfaction with the care team. It always seems better that we should be able to do something to help someone. Especially when the literature says what you're doing yet before, when you terminated, we weren't helping them. You really weren't. You aren't. You really aren't. That's what the data says. Not me, that's what the data says. And every study says the same thing, actually. I just use those few studies about anomalies. It's an opportunity for physical examination and autopsy. It also gives me a chance to get genetic testing, confirm diagnosis, and a guide counseling for future pregnancies. It also changes labor and delivery to a very much different place, because now we're providing supportive and family-centered, parent-centered care to our patients. And they're being allowed to be parents, whatever time we give them, right? And I put this up here because it reminds me always. There was a time when the American Medical Association, which is true actually, and our good friend the doctor, more doctors smoke Camels than any other cigarettes. Because cigarettes weren't associated with lung cancer, you know. Do you know what causes lung cancer? You know that, right? You know that, correct? You understand it's an association, not a cause, right? You understand the difference, correct? You can never prove the causation. It's an association. Of course, nobody who doesn't smoke is get lung cancer, right? So remember, doctors, when they do things, and your professors do things and tell you things, maybe like the doctor who's smoking chemicals. So maybe it's not such a good idea to terminate all the pregnancies. Maybe there's something else you should be thinking about. Maybe you should think creative about taking care of your patient another way. Maybe there's something out there that you could do with your influence and I have a totally different revolutionary idea in your care of one of your patients. It could be what you do here, I don't know. But if you keep thinking about all you have in your tool chest is a hammer, everything's a nail. Everything's a nail. Well, I want to talk a little bit about some of the psychological things because, unfortunately, in our moral, ethical, legal world, I can't randomize you to have your termination of pregnancy and you not with your anomalies. Right? I can't do that in the morning, right? I can't. So, what we did was we did a very interesting study. I did one of my friends and colleagues who's actually a PhD nurse and a midwife and a sonographer and a brilliant individual. Went and did 15 women who did hospice behaviors and did hospice and tried to find out narratives about validating behaviors for care of their children. And it's probably about as close as we're going to get unless we have some sort of large, sort of a follow-up study, which if someone would pay for, do I think lives to help them. So it's all about time and money, isn't it? Well, what we found was some very interesting things. And of course, there's no surprise, right? If you treat the baby like a person, or you acknowledge the value of the baby's life, or you show ultrasounds, and you do things that are affirming, mothers and fathers perceive that as validating in the narrative, right? If all you ever show them is, look, there's your baby with MedSFLA again, which they already know, by the way, we have to show it to them 12 times, that patients naturally are not very happy with that. That's not validating behavior. The other thing that is very interesting is, in spite of all of the stuff you hear about non-directed counseling, every patient who comes to me has been told and pressured to abort their child. Everyone. Everyone. Every single one. So does that sound like non-directed counseling to anyone here? I'm just asking the question. What the mom said is, once they've made their decision, please don't pressure me anymore. Respect my decision, my autonomy, and let me have my baby. Forever long it is. Right? Take care of me. Don't abandon me, which is what Cecily Saunders would say. Critically important, I know we asked about birth plans. It's like the bigger the birth plan, the higher the risk for cesarean section. It seems that way. But this is one of the times when the birth plan is critically important, so everybody knows what you're supposed to do. If you drop the ball on this one, it's not so good. My worst story I ever told on this, and it happened a few years ago, and it wasn't me, by the way, was that we had a baby who had been a stillborn and had anomalies. And the parents wanted to take the baby home to bury it. Unfortunately, he went to pathology, and they basically discarded the baby, burned it. And that doesn't go well. Yeah. So, when parents want you to do something, please make sure you do it. And it wasn't done badly. This was not on purpose. This was a total clerical error. It was not told to go to the funeral home or disposal. So they disposed. This is my daughter, Mercy again. We're on the upper shores of Glendalough. Now, anybody else in Ireland? Oh, yeah. Been to Glendalough here? Oh, beautiful. Get a chance to go to Ireland. I was strong. I was at a meeting, and it's great. This is the part about being an accommodation. People invite you, pay your way. To bring PowerPoint slides, tell bad jokes, show pictures of your children, your parents. So this is Glendalough, gorgeous area. About caregiving. Well, my favorite story about this, you gotta love nurses, okay? You really do. I'm very nurses here, ex-nurses, former nurses, still nurses. But, bless their hearts, you don't need to do every 2 hour pilot science on them and interrupt the integrating process, right? So don't do that. Write stuff is like reasonable. So not in there constantly doing stuff. And then don't tell them what to do when they go home. Like, mom's going to get ignored if she's having 34 weeks. No one tell them about that. Because when her breasts are the size of watermelons 3 or 4 days later, and she's not got a baby, she's always not going to be happy with you. So again, how you care is how it works, right? Mother's feelings and told them, don't tell me how to feel, expect me to get over it. That's one of the things you're just going to deal with, and you're not. That's the child, you're not going to deal with, right? Doesn't happen that way. What about Perinatal Hospice in 2012? I just looked at this about 2 weeks ago. I started doing this in about 1996, probably before you were born, right? Over 15 years, there's now over 150 programs in the United States. Just 2 years ago, there were 80. So people are starting to understand maybe there's a better way of thinking about taking care of people in adverse situations. There's 15 in Italy, and there are all sorts of kinds of them. There's hospital-based, there's freestanding, there's community-based. And everybody asks me, well, why don't you have an organization? I go, that's Congress. Right? I don't want to know. Bureaucracy is the death of this stuff, right? Doesn't mean guidelines aren't important, doesn't mean good care is not important, but bureaucracy kills this stuff. This should come from people's desire to do this in their hospital, not in some franchise. Frankly, that's why they're doing it. Well, I think the challenge for those of you sitting here, for me as well, is to examine your response and motivation about why you do what you do. Is it about you or is it about your patient? Rethink about your care outcomes. Again, I can share with you multiple things that have changed in the last 20 or 30 years in terms of care of neonates, in terms of care of just adults, and people in general, right? You can think about all sorts of medical advances that have been made. And that's what I'm saying is rethink about how we do this. Why can't we offer hospice? For their orders. We also have this tendency to withdraw from painful situations, and that is very true. Some people just don't want to do this stuff, and I'm okay with that. But unfortunately, if you do medicine, patients will die. Well, unless you're a dermatologist. Just in, there's some bad skin disease now. So there's also institutional barriers, which is the biggest thing I find is there's stereotypes. You students think there's stereotypes out there. Surgeons don't talk to the interns, the interns don't talk to the pathologists, the pathologists don't talk to the ER doctor. I mean, it goes on and on and on. Like my favorite joke, you know what you do if the door's closed, how do you tell you got an internist? If the doors of the elevator are going to close versus surgeon? Well, the internist will put his hand in to stop the door. Because he doesn't use his hands. The surgeon will put his hand in because he doesn't use right. That's the kind of jokes, right? Is that, am I right? Okay, yeah. Or your doctor, rule out this, rule out that. The internist rule out this, rule out that. The surgeon says, shoots the doctor and says, send it to pathology. Identify it. So there's always barriers and standards and practices that people get into. They get into their little mindset. I don't say question everything, but you want to be thinking about when somebody says something to you, my first response is, what's the data? What's the paper? You all are blessed beyond belief. You can go to see the internet in the Library of Congress or whatever, and look it up, and it's at your fingertips like this. You know what that was called when I was in this place? It was called the library. I would have to go through those stacks of books like this and look up those stupid articles and then try to find them. Miserable experience. Miserable experience. Don't believe it if it's not in the literature. Look it up. Look at the primary papers. Go back to the primary papers. See if the data's there. If it's not there, maybe it's just another one of those medical urban legends. Well, that's just the way it's done. Well, that's a bad reason to do it. I think we need to continue to collect data, do research. I think you'll like to see more multi-center experiences. I do have more people talking about it and talking about their data, unfortunately not publishing it, nor are they sharing it. So if you have data, then share it, show it, publish it, present it. I mean, that's how we get smarter. We share these things, right? The little neural network. Centers of excellence need to be established. I agree with that. That's why more people are starting to do this stuff, so they have places to center, right? And the reason I'm here is to talk about communities and patients, medical students, residents, anybody who wants to hear about it, and talk about how to do this better. And I like this picture because it shows my daughter. I'll show you she is now. She's a little tiny girl. Way over here. That's her. And this is at the UN, which I never mentioned, obviously, in a foreign North Mile. And this is in the UN in National Building. They're singing there for the 50th anniversary of the Charter. And they're the only children's planet in America that will invite to that. So that's pretty cool. Pretty impressive. Well, what's my final conclusion? And I'll let you go because we have class and you probably want to go eat some more, whatever you all want to do. There's a lot of people out there. If you start asking around people, there's people who've had MedSFLA for trisomy 13s or 18s or stillbirths, or people with children who've had anomalies that you know or have been around. If you're going to do a center of gynecology or primary care or pediatrics, you're going to see this stuff, okay? There's a lot of people. Patients want it, all right? If no other reason, if your patient wants something, perhaps you should think about offering it. Or at least ask them if they want to do it, right? If you don't want to do it, send it to somebody who does. Refer them to somebody who will do it. There's no increase in morbidity. I think there's actually less. I think the psychological literature is quite clear. And I can quote you many, many studies on this, that just wanted babies in particular are just not good to terminate. If they die, it's one thing. Actively killing the babies is a whole different thing. It just is different, right? And I think it also shows what we want to be in the position is compassionate. For our patients who are the most helpless. I mean, these are babies who just need our help. And families need our help. That's what they want. And if you have any questions or comments, I'm glad to entertain them.